Okay, welcome to round 2 of Quest Integration. What's different about long-term services supports? So there will be 3 takeaways from today's presentation. The first is language matters. The second one, we'll do a quick review of what the 4 changes are to the beginning of the process with enrollment, and then we're going to begin to kind of move through the process and get into the service coordination and what changes are going to be entailed with that. So language matters. As I'm starting to get into pamphlets, documents, member handbook, I'm seeing some language that is just frankly not politically correct in the world of long-term services supports. And so some of those terms would include mentally retarded, physically disabled, handicapped, crippled, mentally disabled. There's a whole slew of language like that. This is just a good high-level example of that. The language we should be using instead of that is individual with an intellectual or developmental disability or person with a disability. Kind of the key difference here is that it's always person first, person with a disability, not disabled person. So this is a nuance that needs to be reflected in everything to MedQuest to show that we know what we're talking about. So reviewing the changes coming forward, so the 834, new member comes in via an 834 file. There are a couple of things that happen when it goes to customer service, to claims, and to clinical operations. So the 4 main changes we're talking about here. One is we need a faster way to turn things around when someone has been identified who is needing a health and functional assessment and their Medicaid or MedQuest eligibility is tied to the receipt of home and community-based services. We have a 7-day turnaround time on that. We're also going to need a faster connection from the 834 file to accounting to account for member cost-sharing responsibilities. People reside in nursing facilities, assisted living, etc., have to pay a certain percentage cost share, and we have to be able to account for that and figure out so the facility gets it and we're not having to pay for it, kind of thing. Another one is a faster connection from customer service to service coordination to get an assignment for caseloads. Again, if someone has been identified through the member survey that they potentially have some needs that we need to address, we send that over to a service coordinator and they have 15 days to get out and do a face-to-face health and functional assessment. And just one of the realities of this is we know our current experience in customer service is about 7 to 8 minutes, 3.5 minutes is our average call time. And the QEXA dashboard that we can see, the 2 QEXA plans right now, they're doubling that to 7 to 8 minutes. So we know this is going to require more resources in customer service. So long-term services supports are all about perspective. And here's just kind of a funny quote. A retiree is going down the wrong way down the H1 and he gets a call from his wife. "Take care," she says. The radio says some idiot is going the wrong way. "One idiot," says the old man. "I can see hundreds." So just a different perspective on things there. So we're now going to kind of go into, now that new members come in the system, that new member is now kind of in the service coordination area, which is also going to touch on care coordination and medical management, but we're going to kind of set those aside until the next week and just focus on the primary changes with service coordination today. As a quick refresher in terms of definitions in the RFP, care coordination is something that we do right now with pharmacy benefit, disease management, transitions of care. The one side of the fence for care coordination for us is activities that are conducted in the office via telephone or written correspondence. By definition, service coordination denotes face-to-face assessment, quarterly visits with that member, so it's kind of more in the field focus. So that's kind of really the difference between care and service coordination. So there are 4 service coordination operational changes that we need to kind of just high level think about, and then we'll go through the kind of function with that. What does that mean for us? One is service coordination staff have to have either be licensed nurses or social workers, so that's different than what we're currently experiencing. There are 5 caseload cohorts, as you call it. So SCHN stands for Special Healthcare Need. So when a member comes in and a health and functional assessment has been performed, that person is really going to be put into one of 5, actually 6 technically kind of areas. The first is service coordination focused on children, service coordination focused on adults, service coordination focused on individuals who reside in nursing facilities, service coordination who focuses on people in the HCBS program, and then an offshoot of that is people who elect not to use home and community-based services but want to do the self-direction program. And then there's everyone else, and just kind of as a high level, so you see in parentheses there 1 to 200, 1 to 250. These are caseload service coordinator to member ratios that are mandated in the RFP, and those are significantly different than what we currently do. I mean, we right now have, it's probably 1 to 7,000 or something like that when you look upstairs. So it is significantly different. And then all the other shins is everybody else. So as a high level, the shins, at least kind of the initial outlook from the state is that's 5% of our population. So the other 95% fall into people we already currently serve in the way we currently serve them, so there's not a lot of huge changes there. Mandatory face-to-face member visits, and again, field-based service coordination. So these staff will be going into homes, apartments, nursing facilities, hospitals, so all based out in the field, not here via phone calls. So there are kind of a couple of big functional impacts from those 4 big changes. One is in human resources. So the state basically has said, health plans, you need to use nurses and social workers. Health plans, you need to divide up your population with defined caseload to member ratios. So really, I mean, all 5 health plans are running the same front-end model now. So we're really competing with other plans for the limited amount of nurses and social workers that are available on the island. It's in the same staffing model. So really there's some bigger questions about what are we going to do to differentiate ourselves. Is it purely in mission? Is it in recruiting, salary, benefits, telecommuting, other things? So we just need to really think about what we're going to do to attract and retain staff in that capacity. The 5 caseload cohorts, mandatory face-to-face visits, and field-based service coordination, that's also going to fall. A lot of issues are going to traipse into the IT world with that of guiding care. Is our system, does it properly manage and track members moving between groups? Because someone could be a non-SHIN or just receive care coordination, then maybe be in a SHIN group for a while, then transition out. Keikis could turn over 21, go into the adult group so that people can transition out of nursing facilities. So there's a lot of movement within those groups. And just working out in the field, staff needs to be able to use laptops, cell phones, whatever those little hotspot, car, all that stuff, to be able to consistently have access to the internet and our systems, to work out of the office. So I see those as really big issues related to IT. So when I start looking through all the different areas we've gone through, we've touched on all of these: human resources, IT, service coordination, customer service claims, clinical ops, and enrollment. So we're just going to keep moving through each general section here as we kind of move forward, going forward. So